Hello, good evening from Korea. I'm Hyun Chang-im from Kyungju University, Seoul, South Korea. I'm a moderator of today's live study. Today's live study will be performed by Dr. Jung-Hyun Park. Today's topic is the easy way for implant placement using digital guide. Today's patient is 8 years old female, and she has been used removable partial denture for a long time, and at some time point she became a bit tired of using the partial denture, so now she wants to have fixed implant restoration, and her present illness are hypertension, diabetes, hyperlipidemia, and rheumatoid arthritis. It's a very classic old patient with many systematic disease. This is a panoramic radiograph. There are missing tooth area on the posterior segment on the upper left area and the lower right areas. And the tooth number 24 looks periodontally and endodontically compromised. And this is a clinical situation of the patient. We can find some little depression on the missing tooth area, on the upper left area and lower right area. And today's surgical plan, today Dr. Park will place 3 implants on 24, 26, and 46 area using digital guide system. And he will also perform guided bone regeneration with using osteon 3 collagen and collagen membrane 2. We have already seen the panoramic radiographs, and this is a CBCT. This area is a 24 area, and we can see periapical region in the apical part of the tooth number 24, and the buccal thickness of this tooth is approximately 1 millimeter. And this is a 26 situation. Bone height is, I think, enough for having implant in a standard length. And but on the buccal side, we can see some ridge resorption. This is a situation of 46. Compared to the clinical photo, bone width looks nice, but I think he may perform contour augmentation for better tissue contour. And this is the planning for producing digital guide. And let's see the Dr. Park's plan. For 24 area, the implant will be placed palatally for primary stability and leaving a gap between the implant and the buccal bone surface. And the gap, I think, will be filled with a bone substitute material. And this is planned for 26 area. He will place the implant subcrestally. I think he wants to avoid bone augmentation procedure here. And this is for 46 area. And for this area, the implant will be also placed subcretally. And compared to the clinical situation, we can see a lot of bone on the buccal surface. But as we also checked in the clinical photo, there are some tissue depression. So for this area, he may do some tissue augmentation here. And this is implant. This is you can see the implant position and the crown, future crown status. And this is a 46 area. We already checked this plan. And until now, we very briefly checked today's plan. And now I want to share similar cases before starting live study. The cases was done 2021 Maybe the one of the this case is from one of the live surgery at the time, and the patient you are seeing needed implant treatment on the upper left posterior area from the first premolar and the second molar area. Prior to implant surgery, the teeth 26 and 27 were extracted. And after 1 month, implant surgery was performed on the 24, 25, 27 area. The teeth 24 and 25 were extracted right before implant placement for immediate implant placement. And there you can see some bone defect predominantly on 26 area. And using a digital guide, the implant were placed in an appropriate position, like that. And then bone augmentation using osteon 3 collagen and collagen membrane was done for the 26 area. And for all implant, submerged healing was applied. You can see the healing abutment on the fixed on the picture area. This is the healing after 1 month. And this is a healing after 1 month. And this is a panoramic radiograph after completion of the implant treatment. This panoramic radiograph were taken at 1 year after the surgery, and you can see the very stable marginal bone level on the implant area. Okay, I think the operation room is ready. It's time to meet our live surgery patient. I think right before the surgery, the tooth number 24 is already extracted. After, I think he checking the fitness of the guide. He marked the location where the implant will be placed on the 26 area. Then he is starting crestal incision using number 12 blade from the very distal area to the distal surface of tooth number 25. This patient is a bit old patient, so for this kind of patient, we need to speed up the surgery, not to giving some kind of trauma, too much trauma to the patient. He made crestal incision. And he's making sure the incision on the distal surface of the 25. Then he is continuing the incision, the circular incision. Then he reached on the 24 area, and he is making vertical incision on the distal area of the canine. He wants to save the papilla of the canine, and that's why he made papilla sparing vertical incision. And he's making distal cupping incision for better visibility on the 26 area. He is using a curette to sever the attachment of the flap on the bone surface. I think there is some bony irregularity on the 26 area, and it looks a little difficult to raise a flap. He's also severing the fiber. And he's raising the flap from the medial surface of the buccal flap toward the distal area. We can see the socket area having some granular tissue. Sometimes distal surface of crown, it is a bit hard to having a clear cut. So I think that's why he used thread to cut old fiber on the distal surface of the crown. And you can see the device retracting the patient lip and cheek. The device called Obturagate. And this is a latex-free cheek and lip retractor. For me, I sometimes use this kind of retractor when I do the intraoral scanning. It is a good device to have the better visibility. You can see some bone irregularity on 26 area. But as we already seen on the CBCT, the width of the bone looks not bad. I think he want to make incision, palatal incision, and he is continuing. He is making circular incision on 25 area, and he is continuing papilla sparing incision toward the palatal side. For 24 area, the implant should be placed palatally, so it's very important to raise the palatal flap sufficiently for better visibility and accessibility. Otherwise, implant sometimes placed buccally, and as you know, the buccally placed implant is very susceptible for mucosal recession afterward. And the extent of flap elevation, I think, is sufficient. And he is removing granular tissue in the socket area. We can see penetration on the apical part of the 24 area. And he is further increase the amount of flap elevation. To remove the granular tissue from the penetrated site. And now we can clearly see the penetrate defect. And from the buccal side, he pushes the tissue into socket. Then he is trying to removing the granular tissue from the socket area. After pushing the tissue into the socket, then he inserted the curette in the socket, and he degranulated the tissue from the socket. And we remember that this tissue is periodontally, also endodontically compromised. So it's very important to remove the granular tissue completely. Incomplete degranulation sometimes make peri-apical region after implant placement. And he inserted the guide. He made a partial guide. The fitness of the guide looks good. And he rechecked the fitness guide. And depending on the mouth opening, it's sometimes hard to use surgical guide, especially for posterior segment. Especially for Asian, it's very difficult to use the digital guide for the very last tooth area. And he is using one flattening drill. It's bone plating drill for 26 area. And this drill is to flatten the bone irregularity, to make it easy to place implant fixture in a proper position. After flattening the bone surface, he's now starting to he's starting to make the osteotomy. He's checking the position. I think the bone quality of the surgical site is maybe D3. Very little resistance when he was drilling. And you can see the height of the guide, and you also saw the height of the drill and extension. Because of those points, for the patient with a little mouth opening, it's very hard to use the guide on the very last tooth area. In that case, we make some kind of slit on the buccal surface to better accessibility of the drill. He drilled for the implant with a diameter of 4.5 millimeter. I think this patient is old, and she may have a very may not excessive biting force. So that's why Dr. Park does not want to place wide diameter implant. And he is placing implant. The diameter of the implant is 4.5, and the length is 10 millimeter. The bone quality seems to be very soft. He connected the instrument for latchet, and he is further inserting the implant. And he is starting to drill to the 24 area. You remember the healing of this area is not complete. So for this area, even though he is using the guide, he should be careful not to slide drill the buccally. And he's enlarging the osteotomy. And he made the final drilling with a low RPM. We can see the tissue remnant on in the socket area. I think this is a bone debris from the drilling. That's why he did not remove the tissue in the socket. And he is inserting the osteon 3 collagen. Osteon 3 is composed of 60% of hydroxyapatite and 40% of beta-triphosphate, and also collagen is combination of osteon 3 and the collagen component. It's unlikely the particle type of the bone graft. You can see no displacement of no scattering of the bone material because of the presence of the collagen in the material. And before placing the implant, he inserted the bone material into socket. Then he is placed the implant. During the implant placement, the bone graft material naturally spread to the gap defect, and you can see some bone graft material from the penetration defect. For final insertion, he is using latchet. This implant, the diameter of this implant is 4.0 and the length is 10 millimeter. He is strolling to remove the connecting part. Sometimes it takes time to remove the instrument from the surgical guide. And I think the all implant were placed subcrestally. For 26 area, I think the 1.5 meter subcrestally. And for 24 area, the bone material should be protected by the membrane. I think he is going to use the membrane. And he is trimming the collagen membrane too. And the collagen membrane too has a excellent durability for a long time, and the characteristic is very soft and but tense, and we can use the bone tack or screw for fixing the membrane without tearing the membrane. This membrane is bovine origin. And he connected the device for making profile for healing abutment, because he did subcrestal implant positioning. Sometimes the healing abutment does not go properly into the implant picture, and that's why he making the proper profile for healing abutment. And this instrument for making proper profile for healing abutment. you can see some bone removal after using the instrument. Then he is connecting the abutment to the implant fixture. And the abutment seated properly without interfering the adjacent bone tissue. I think the patient is a little bit exhausted. And Dr. Park is trying to make the patient very comfortable. Yeah, you can see the subcrestal implant position. From the palatal crest, I think the implant platform were placed 1 millimeter below. No, at least 1.5 millimeter below. And he made a hole to the collagen membrane too. This hole is for healing abutment connection to the fixture. And we can make this kind of hole using punch or scissoring. The hole should be large enough to interfering healing abutment. When we, in case of a small hole on the membrane, sometimes during healing abutment connection, the membrane become twisted or displaced to the unwanted area. The height of this abutment was 5 millimeter, but he think the 5 millimeter is not enough. So he changed the abutment from 5 millimeter in height to 7 millimeter in height. And he tucked the membrane below the palatal flap. He's checking the stability of the membrane. The membrane should cover the fenestration defect, like that. and he's starting to make suture from medial area of the flap. And from the surgery room, there is a message. After finishing suture, Dr. Park wants taking X-ray. So we will have a little break after finishing suture on that area, on this surgical area. If we started the suture from the distal part of the flap, sometimes the amount of flap for the medial area is not enough. So for me, it's better to start suturing from the medial side to the distal side. And for this surgery, we only do bone. He only did bone augmentation surgery, the 24 area, not 26 area. So the main part of the surgical site is the medial side. So for this kind of surgery, it's wise to start make suture from the medial area. And the two vertical incisions are left. Only one suture, I think, is enough to approximating the flap to the distal cutback side. Then he continuing the suture on the medial vertical incision area. the tissue on the canine area is that mobile, so that's why he stopped the suturing and he taking out the curette to further elevate the small flap to that area to make it easy for approximation of the flap. We can see some tension. And he is making another one stitch in the mucosal area, but we have still some gap between tissue, but I think this is okay, but we can expect some scarring after healing. He checked the stability of the implant using a latchet. Yes, he want to check the implant position from the X-ray, and we will have a small break before starting the surgery on the 46 area. Okay, and he started surgery for 46 area. We can see some coronally positioned mucosa on the 46 area, and he just made the incision, the papilla area between 44 and 45. He's making distal cutback incision. I think there was the tooth remnant. And he is severing the attachment using a curette. And you can see the granular tissue penetrating into the bone. That's why he is using a curette for replanting lingual flap. The healing on this area looks incomplete. And you can see the granular tissue formed mid-crestally. And the granular tissue looks very sticky. Oh, he want to use drill to removing the tissue, because the blade of the drill, the granular tissue is swirling around the drill. And you can see there are some circular defect. And this guide is also partial guide. He is pressing the guide not to displaced, and he is starting drilling. He is enlarging the osteotomy. He is gradually increasing the height and width of the drill. And he will place the implant with a diameter of 4.5 and 10 millimeter in length. This is Superline 2 implant. He is checking the implant position. You see, the implant is not yet fully inserted. And he wants to make a proper implant position without guide. He's pulling out the implant in a reverse motion. I think this, because of the defect, the implant position should be calibrated manually. That's why he pulled out and pushing in the implant without surgical guide. Implants were placed subcrestally with respect to the proximal surface. And on the buccal side, we can see very small descent defect, and the descent defect is just confined on the smooth color of the implant. And I think that because of the total tissue contour, he would make a contour augmentation. I think he will perform same technique as we previously seen on the posterior maxillary area. I think he should make a further flap elevation on the buccal side, because there is not enough space for membrane on the buccal area. He already made a hole to the collagen membrane too. Yeah, he is raising the flap, further raising the flap. And he inserted the membrane below the buccal flap. Then he inserted the membrane below the lingual flap with holding the membrane using the parallel elevator. Then he's connecting the healing abutment through the hole to the implant fixture. Now the membrane looks very stable because of the lingual part of the membrane and the healing abutment. And he's making a space below the membrane to apply the bone substance material maybe. And the material is osteoinsular collagen. He just picked the material using the pinset. And this kind of material very easy to apply to the defect. And the material should be placed crestally. That's why he pushes the material toward the healing abutment. And because of the architecture of the surgical side, you already see the very slant, the buccal surface. The particulate bone sometimes displaced apically, but in case of using the collagen containing bone substance material like osteoinsular collagen, the bone graft material can be stabilized in place so that we can expect better tissue control after the healing. And with using healing abutment, he provides a non-submerged healing, even though he inserted the bone substance material on the buccal surface of the implant. And this kind of procedure reduced the number of surgery. You remember the age of the patient, and this augmentation is not for the major bone augmentation; it's just for the contour. So I think this kind of non-submerged healing GBR is okay for this patient. There are several papers for this kind of the GBR procedure, but as far as I remember, the old paper is using non-submerged type implant, one-stage implant. But he placed implant subscratally, and the descent defect is very small, so that he could have a GBR procedure with a one-stage implant, non-surgery type healing. The patient is very exhausted, and just one stitch is left. The surgery is almost over. And we will have a break time. Okay, the Q&A session will be started in next 10 minutes. Okay, we have panoramic radiograph after surgery. And first, let's take a look at the upper left area. The implants were placed subcrestally. We can see some vertical discrepancy. We can see the vertical discrepancy among the implant. In general, I prefer it's better to make the implant platform even or parallel, but considering the age of the patient, reduce the chair time or minimal trauma were more important. So that's why he placed implant subscratally with minimal invasiveness. And for the 46 area, implant also were well placed subcratally. And maybe after 3 or 4 months, he will connect the final prosthesis. And let's take a look at today's question. And the question, we have only one question. The question is, do you have any tips for healing when using collagen membrane? The question is a bit confusing, but as far as I understand, I think the questioner he asked about the type of healing for the GBR. The basic principle for guided bone regeneration is submerged healing with primary intention. But in some case, like today's live surgery, we have the patient had a very small descent or just small concave defect on the only buccal side of the implant. In that case, I think the non-thermal type healing with bone level implant is okay. And the collagen membrane too is very durable and can be maintained under the prep. So after the sufficient healing period, the membrane is still working, and under the area of the membrane, we can expect a nice regenerated bone. Yes, I think it's time to sum up the case. Today, we have an old patient with several systemic disease. And this kind of patient needs the minimal trauma and reduce the surgical time. That's why the Dr. Park used the surgical guide. And for the minor bone defect, GBR with non-submer type healing can be applied. Thank you for watching today's live surgery. The live surgery will be November 4th. And yes, thank you for watching today's live surgery, and stay tuned on Dentium channel. Thank you very much.